Welcome to this continuing education course on human trafficking for Florida nurses. This course will provide you with the knowledge and tools necessary to recognize the signs of human trafficking, respond appropriately and safely, and connect victims with the resources they need to reclaim their freedom and begin their journey toward healing. This training is provided in accordance with the requirements set forth by the Florida Legislature in Florida Statute 456.0341, which mandates that licensed healthcare professionals complete continuing education on this critical topic. Before we begin, let me outline what you will be able to do upon completion of this course. You will be able to differentiate between the legal definitions of sex trafficking and labor trafficking, including the specific provisions for minor victims under U.S. and Florida law. You will be able to identify at least 5 distinct risk factors that increase an individual's vulnerability to human trafficking, such as a history of abuse, substance use, or unstable housing. You will be able to recognize at least 10 physical, psychological, or behavioral indicators of human trafficking that may be observed in a clinical setting. You will be able to describe the core principles of a trauma-informed approach to patient care and how to apply them when screening for human trafficking. You will be able to select the appropriate mandatory reporting pathway in Florida when suspecting human trafficking of a minor victim versus an adult victim. You will be able to apply best practices for objective and factual documentation in a patient's medical record when human trafficking is suspected. And finally, you will be able to identify 3 distinct types of services available to human trafficking survivors in Florida and list 1 state level and 1 national resource for victim assistance. Now, let's begin with an introduction to Florida's hidden crisis and the critical role you play as a healthcare professional. Human trafficking is a clandestine and devastating crime that exploits the most vulnerable for profit. It is a form of modern-day slavery, a profound violation of human rights, and a significant public health crisis. While it may seem like a distant problem, it is deeply entrenched in communities across the United States, and particularly in Florida. As trusted professionals on the front lines of public health, clinicians are in a unique and powerful position to identify and assist individuals who are being trafficked. Often, an encounter in a clinic, hospital, or pharmacy is the only opportunity a victim has to interact with someone outside of their trafficker's control. Let's talk about the scale of this problem and unveil the staggering prevalence of human trafficking in Florida. For many years, the true scale of human trafficking in Florida was obscured, with official statistics reflecting only the small fraction of cases that came to the attention of law enforcement or social services. However, a groundbreaking state commissioned report has illuminated the staggering scope of this crisis. Researchers at the University of South Florida's Trafficking in Persons Risk to Resilience Lab, designated by a 2023 state law as the official repository for anonymous human trafficking data, conducted a first-of-its-kind study aggregating data from 30 state agencies, nonprofit organizations, and public surveys. Their findings are sobering. In 2024, an estimated 700,000 people were victims of human trafficking within the state of Florida. This comprehensive estimate breaks down into 2 primary forms of exploitation. Approximately 500,000 individuals were victims of labor trafficking, and 200,000 were victims of sex trafficking. The report further reveals the profound vulnerability of children, who are estimated to comprise half of all sex trafficking victims and a quarter of all labor trafficking victims in the state. These numbers position Florida as one of the states with the highest rates of human trafficking in the nation, a reality fueled by a confluence of factors. The state's large population, numerous major cities that host national and international events, extensive network of airports and seaports, and major industries such as agriculture, tourism, and entertainment all create environments ripe for exploitation. The vast chasm between these prevalence estimates and the number of cases officially identified each year highlights the central challenge of this hidden crime. For example, in 2023, the National Human Trafficking Hotline identified 676 cases originating from Florida. In the same year, the Florida Department of Children and Families verified 339 youth as victims of commercial sexual exploitation. This is not a contradiction in data, but rather a stark illustration of an identification gap. The current systems of reporting and investigation are capturing less than 1% of the estimated victim population. This reality reframes human trafficking from a rare, sensational crime that a clinician might encounter once in a career to a pervasive public health crisis they are likely encountering regularly, often without realizing it. The victims are not just statistics, they are patients sitting in waiting rooms, presenting in emergency departments, and filling prescriptions. Now let's define human trafficking so you clearly understand both sex trafficking and labor trafficking. To effectively identify and respond to this crime, it is essential to understand its legal definition. Under federal law, which informs Florida's statutes, human trafficking is a crime that involves the exploitation of a person for labor, services, or commercial sex through the use of force, fraud, or coercion. The Trafficking Victims Protection Act of 2000 defines two primary forms of this crime. Sex trafficking is defined as the recruitment, harboring, transportation, provision, obtaining, patronizing, or soliciting of a person for the purpose of a commercial sex act, where the commercial sex act is induced by force, fraud, or coercion. Labor trafficking, also called forced labor, is defined as the recruitment, harboring, transportation, provision, or obtaining of a person for labor or services through the use of force, fraud, or coercion for the purpose of subjection to involuntary servitude, peonage, debt bondage, or slavery. A critical distinction exists for victims who are minors. Any person under the age of 18 who is induced to perform a commercial sex act is legally considered a victim of human trafficking, regardless of whether force, fraud, or coercion can be proven. The law recognizes that a minor cannot legally consent to commercial sex. Therefore, the means element of the crime is automatically met. This is a non-negotiable legal point that all healthcare professionals, as mandatory reporters of child abuse in Florida, must understand. Let me explain why healthcare professionals are a vital lifeline for victims. Victims of human trafficking suffer from a host of severe physical and psychological health consequences resulting from their exploitation. These can range from physical and sexual violence to malnourishment, infectious diseases, and profound psychological trauma. Consequently, many victims will seek or be brought for medical care at some point during their captivity. One landmark study found that 87.8% of trafficking survivors had encountered a healthcare professional while they were being trafficked. This statistic underscores the immense opportunity and responsibility that rests with the healthcare community. The healthcare setting, whether it is a hospital emergency department, a community clinic, a private practice, or a pharmacy, is one of the few environments where a victim may be temporarily separated from their trafficker and in the presence of a trusted, authoritative figure. This creates a crucial window of opportunity for identification, intervention, and the offering of a pathway to safety. For many victims, a compassionate and knowledgeable healthcare professional may be their first, last, and only hope. Now let's move into Module 1, where we will develop a deeper understanding of the types and dynamics of human trafficking. A foundational understanding of the different forms of human trafficking and the methods traffickers use to control their victims is essential for clinical recognition. The crime is not monolithic. It manifests in diverse ways across various industries and social contexts. Media portrayals often focus on sensationalized stories of kidnapping and physical restraint, but the reality is frequently more subtle and psychologically complex. Let's take a deeper look at the forms of exploitation. While human trafficking is broadly categorized into sex and labor trafficking, these categories encompass a wide range of exploitative activities. Understanding these specific manifestations, particularly those prevalent in Florida, can sharpen a clinician's ability to recognize potential red flags in their patients. First, let's discuss sex trafficking in more detail. Sex trafficking involves compelling a person to engage in commercial sex acts through force, fraud, or coercion. This is a prevalent issue in Florida, with an estimated 100,000 minor victims alone. Sex trafficking occurs in a variety of venues, some hidden and some operating in plain sight. Illicit massage businesses are establishments that are often fronts for sex trafficking. Florida has seen a significant number of these operations, particularly in counties with large population centers and tourism, such as Broward, Palm Beach, and Miami-Dade. Data from the National Human Trafficking Hotline consistently shows illicit massage and spa businesses as a top venue for sex trafficking reported in Florida. Escort services and online solicitation represent another major avenue. The internet and social media have become primary tools for traffickers to advertise victims and recruit new ones. Traffickers may control victims' online profiles and communication, arranging encounters in hotels, motels, or private residences. Brothels and residential operations can range from formal establishments to informal operations run out of apartments or houses. Street-based prostitution is another venue. While not all individuals engaged in street prostitution are trafficked, many are controlled by pimps who use violence, threats, and drug dependency to maintain control. Pornography is also a form of sex trafficking, when victims are forced or coerced into producing pornographic material. Now let's examine labor trafficking in greater detail. Labor trafficking is the most common form of human trafficking worldwide, and according to recent estimates, in Florida as well, with approximately 500,000 victims in the state. It involves compelling a person to work or provide services against their will. This exploitation can occur in both legal and illegal industries. Given Florida's economic landscape, healthcare professionals should be particularly aware of its prevalence in several key sectors. Agriculture is a major area of concern. Migrant and seasonal farm workers are highly vulnerable due to factors like poverty, language barriers, and immigration status. Traffickers may use debt bondage, threats of deportation, and control over housing and transportation to exploit workers in Florida's fields and groves. Hospitality and restaurants also present significant risks. The state's massive tourism industry creates a high demand for workers in hotels, motels, and restaurants. Traffickers may lure individuals with promises of good jobs only to subject them to excessively long hours, withheld wages, and poor living conditions. Construction is another sector where labor trafficking occurs. High demand for labor can lead to exploitation, where workers are paid little to nothing and forced to work in unsafe conditions. Cleaning and janitorial services also see trafficking victims who may be forced to clean commercial buildings, hotels, or residential properties under coercive conditions. Retail and manufacturing are additional industries where exploitation can occur in factories and retail establishments. Domestic servitude deserves special attention as a distinct and particularly insidious form of labor trafficking, where victims are forced to work in private residences. Victims, who are often nannies, housekeepers, or caregivers, are uniquely isolated from the public eye. This isolation makes identification and escape extremely difficult. Their employer is also their trafficker, controlling every aspect of their life, including their housing, food, communication with the outside world, and freedom of movement. Because the exploitation occurs behind the closed doors of a private home, it is hidden from labor inspectors and law enforcement, making a healthcare visit one of the only potential points of intervention. Now let's discuss the core of the crime, which can be understood through what experts call the action means purpose model. This framework helps break down the crime into its essential components and is useful for determining whether a situation meets the legal threshold for trafficking. The action refers to the trafficker's conduct. The law specifies actions such as recruiting, harboring, transporting, providing, or obtaining a person. The means is the method of control used by the trafficker. The three key means are force, fraud, or coercion. The purpose is the trafficker's criminal intent, which is to subject the victim to involuntary servitude, peonage, debt bondage, slavery, or a commercial sex act. For a situation involving an adult to be classified as human trafficking, all three elements, action, means, and purpose, must be present. However, it is critical to remember the exception for minors in sex trafficking. If the action is to recruit, harbor, or otherwise involve a person under 18 for the purpose of a commercial sex act, the means element does not need to be proven. The act itself is the crime. Now let's examine in detail the mechanisms of control, specifically force, fraud, and coercion. The means element is the heart of human trafficking and what separates it from other forms of labor exploitation or consensual commercial sex. Traffickers are masters of manipulation and control, using a variety of tactics to break down a victim's will and ensure their compliance. These methods are often psychological and subtle, which is why a victim may not appear to be in distress or physically restrained. A victim's apparent compliance or even defense of their trafficker can be a symptom of intense psychological coercion and trauma bonding, not an indication of consent. Understanding these mechanisms is crucial for seeing past a victim's potential cover story or fear based silence. Force is the most overt form of control and involves physical and sexual violence. Examples include beatings, sexual assault, rape, physical restraint, and starvation. Traffickers use force to punish victims for disobedience, to intimidate them into compliance, and to establish dominance. In a clinical setting, this may present as bruises in various stages of healing, fractures, burns, or signs of sexual trauma. A particularly insidious form of force is the use of drugs and alcohol. Traffickers may intentionally create or exploit a substance use disorder, using the threat of withdrawal as a powerful tool of control to compel a victim to continue working or engaging in commercial sex. Fraud involves deception and false promises. Traffickers often prey on a person's hopes and vulnerabilities by presenting a fraudulent opportunity that seems too good to be true. Examples include fraudulent job offers where a trafficker promises a high-paying job in another city or country, only for the victim to arrive and find that the job does not exist and they are now indebted to the trafficker for transportation and housing costs. Another example is what is known as the lover boy or Romeo pimp tactic, where a trafficker feigns a romantic relationship to gain a victim's trust and affection. Over time, they manipulate this emotional bond to coerce the victim into commercial sex, framing it as a way for the victim to prove their love or help the couple financially. Fraud can also take the form of misrepresentation of conditions, such as lying about the nature of the work, the hours, the pay, or the living conditions. Coercion encompasses a wide range of non-violent psychological tactics used to intimidate and control a victim. These psychological chains can be just as powerful as physical ones. Common forms of coercion include threats of serious harm, such as threatening to harm or kill the victim, or more often, their family members and loved ones if they try to leave or report the situation. Debt bondage is another very common tactic, especially in labor trafficking. The trafficker imposes a large and ever-increasing debt on the victim for supposed costs like transportation, recruitment fees, food, and housing. The wages paid are so low that the victim can never repay the debt, trapping them in a cycle of servitude. Threats of legal action or deportation are also powerful tools of control for victims who are undocumented immigrants or who have been forced to participate in illegal activities. Isolation is another key tactic where traffickers systematically isolate victims from their support networks by confiscating phones, restricting communication with family and friends, and controlling their movement. Psychological manipulation can include gaslighting, shaming, humiliation, and creating a sense of learned helplessness, making the victim believe they are worthless and have no other options. Now, it's important that we address some common misconceptions about human trafficking because these myths can create significant barriers to victim identification. A healthcare professional who is operating under these false assumptions may fail to recognize a victim who is right in front of them. It is vital to separate fact from fiction. The first myth is that human trafficking always involves kidnapping or violent physical force. The reality is that while violence is a tool traffickers use, the most common methods of control are psychological, including manipulation, trickery, fraud, and threats. Many victims are lured in through false promises of a job or a romantic relationship, not abducted off the street. The second myth is that human trafficking requires movement across state or national borders. The reality is that this is a common confusion with human smuggling, which is a crime against a border. Human trafficking is a crime against a person and requires no movement at all. A person can be trafficked in their own house, in the same town where they grew up. The third myth is that traffickers only target strangers. The reality is that a significant number of traffickers are people known to the victim. Many survivors have been trafficked by romantic partners, spouses, and even their own family members, including parents. The fourth myth is that all human trafficking involves commercial sex. The reality is that labor trafficking is believed to be more prevalent than sex trafficking, both globally and in Florida. However, sex trafficking often receives more public and media attention. The fifth myth is that victims are physically restrained and cannot leave. The reality is that while physical restraint can occur, it is more common for victims to be bound by invisible chains of fear, shame, debt, threats against their family, and complex psychological manipulation. They may have opportunities to leave, but are too terrified or manipulated to do so. The sixth myth is that if a person initially consented to a situation, such as agreeing to a job or to engage in commercial sex, it cannot be trafficking. The reality is that initial consent is irrelevant if a trafficker later uses force, fraud, or coercion to maintain control and exploit the person. A person cannot consent to be enslaved. The seventh myth is that victims will always ask for help if given the opportunity. The reality is that victims often do not self-identify or ask for help due to intense fear of their trafficker, shame, guilt, loyalty forged through trauma bonding, or fear of being arrested or deported. They have been trained to distrust authority figures, and it can take a long time to build enough trust for them to disclose their situation. By understanding the diverse forms of exploitation, the nuanced methods of control, and the reality behind the myths, healthcare professionals can develop a more accurate and effective lens for identifying potential victims of human trafficking among their patients. Now, let's move into Module 2, where we will discuss how to identify at-risk populations and clinical indicators. Traffickers are opportunistic predators who actively seek out and exploit vulnerabilities. They do not target people at random. They identify individuals with specific unmet needs or pre-existing traumas that make them susceptible to manipulation and control. Understanding these risk factors is not about blaming the victim, but about recognizing the social and individual circumstances that can place a person in a trafficker's path. For healthcare professionals, this knowledge can help raise the index of suspicion for certain patient populations. When these underlying vulnerabilities are combined with observable clinical indicators, whether physical, psychological, or behavioral, a clearer picture of potential exploitation can emerge. Let's first examine the factors that increase vulnerability to trafficking. Certain life experiences and circumstances can significantly increase a person's risk of being trafficked. Traffickers leverage these vulnerabilities, offering a false solution, such as love, stability, money, or a sense of belonging to a person's desperate need. Clinicians should be aware that patients presenting with a history of the following are at a heightened risk. History of abuse and trauma is one of the most significant risk factors. A history of child abuse, neglect, sexual assault, or domestic violence creates deep-seated trauma that traffickers are adept at exploiting. Adverse childhood experiences, commonly referred to as ACEs, are particularly relevant. A Florida-based study of youth in the juvenile justice system found that a high number of ACEs was a significant predictor of human trafficking victimization. Runaway and homeless youth are also at high risk. Young people who have run away from home or are experiencing homelessness are disconnected from protective support systems and are often desperate for basic necessities like food and shelter, making them prime targets for traffickers. Substance use disorders increase vulnerability as well. A pre-existing substance use disorder can make a person vulnerable, as a trafficker may offer drugs as a means of recruitment and later use the addiction as a tool of control. Conversely, traffickers may introduce drugs to a victim to create dependency. Mental health conditions also play a role. Individuals with untreated mental health conditions such as depression, anxiety, or post-traumatic stress disorder may be more susceptible to a trafficker's manipulation and control. Poverty and economic instability are major factors. Desperate financial circumstances can lead individuals to accept fraudulent job offers that are actually trafficking schemes. The promise of a steady income or a better life can be a powerful lure for someone facing extreme poverty. Involvement with child welfare or juvenile justice systems is another risk factor. Children and youth in the foster care system or who have been involved with the juvenile justice system often lack stable family support and may have a history of trauma, making them highly vulnerable. Recent migration or immigration status also increases risk. Migrants, refugees, and individuals with temporary or undocumented immigration status are often targeted. They may be unfamiliar with the local language and laws, isolated from their communities, and fearful of interacting with authorities, which traffickers exploit by threatening deportation. Now let's discuss how to recognize the red flags by examining the clinical indicators of human trafficking. While a patient is unlikely to disclose that they are being trafficked, their body and their behavior may tell a story. It is crucial to remember that no single sign is definitive proof of trafficking. Many of these indicators can be associated with other conditions, such as domestic violence or substance use. However, a pattern or cluster of these indicators, especially when combined with the risk factors we just discussed, should prompt a healthcare professional to consider human trafficking as a possibility and initiate a safe and private screening. Let's start with physical health indicators. The physical toll of trafficking is immense, and victims often present with health issues directly related to violence, neglect, and hazardous working or living conditions. These are often the chief complaints that bring a patient to a healthcare setting. Signs of physical trauma should always be a red flag, particularly unexplained or poorly explained injuries. Look for bruises in various stages of healing, burns, especially those with a pattern, such as from a cigarette or an iron, cuts, broken bones, or signs of blunt force trauma. Repeated injuries or a history of frequent emergency department visits for trauma are highly suspicious. Signs of sexual assault and exploitation are common findings and include recurrent or multiple sexually transmitted infections, pelvic inflammatory disease, urinary tract infections, genital or rectal trauma, and repeated pregnancies or abortions. Neglect and malnourishment are often present because victims are frequently deprived of basic necessities. Signs can include significant weight loss, dehydration, poor hygiene, and severe dental problems, which are particularly common in children who have been trafficked. Occupational injuries should be noted in labor trafficking cases. Look for injuries consistent with unsafe working conditions, such as musculoskeletal injuries from repetitive strain, respiratory problems from poor ventilation, or skin conditions from exposure to chemicals. Neurological complaints such as headaches, dizziness, memory loss, and other neurological symptoms can result from traumatic brain injuries caused by physical abuse or from the extreme and prolonged stress of the trafficking situation. Branding tattoos are a highly specific indicator of trafficking. Traffickers may tattoo victims with their name, a gang symbol, a barcode, or phrases like property of or for sale to signify ownership. These are often found on the neck, back, or other areas of the body. Now let's examine psychological and behavioral indicators. The psychological trauma of being trafficked is profound and can manifest in a patient's demeanor, communication, and behavior. These indicators may be more subtle than physical signs, but are equally important. Affect and mood are important to observe. The patient may appear fearful, anxious, hypervigilant, depressed, or emotionally numb, which is sometimes described as flat affect. They may also exhibit hostility, aggression, or extreme submissiveness. An inconsistent or scripted history is a significant red flag. The patient may provide a story that is vague, contains contradictions, or seems rehearsed. They may be unable to provide specific details about their injury or illness, or their explanation may not align with the physical evidence. This is often because the trafficker has coached them on what to say. Disorientation may be present. The patient may not know their location, the current date, or be able to provide an address. They may seem disconnected from their surroundings. Avoidance and fear are common. The patient may avoid eye contact, be reluctant to answer questions, or appear fearful of law enforcement or authority figures. They may also be resistant to assistance or treatment. Symptoms of trauma should be observed. Look for signs of PTSD, such as flashbacks, nightmares, and being easily startled. Suicidal ideation and self-harming behaviors are also common. Trauma bonding is an important phenomenon to understand. A victim may express loyalty or affection for their trafficker or defend their actions. This is a psychological survival mechanism known as trauma bonding or Stockholm syndrome, and it should be understood as a symptom of trauma, not as an indication of a healthy relationship. One of the most significant red flags in a clinical setting is the presence of a controlling companion. This is a person who accompanies the patient and attempts to control the entire interaction. This person may be the trafficker or someone acting on their behalf. Watch for refusal to separate. The companion insists on staying with the patient at all times, including during registration, the examination, and procedures. They may refuse to allow the patient any privacy. Speaking for the patient is another warning sign. The companion answers questions for the patient, interrupts them, or corrects their answers. They may not allow the patient to speak for themselves. Controlling behavior is evident when the patient appears fearful of the companion, defers to them before speaking, or seeks their approval. The companion may exhibit overly jealous, protective, or domineering behavior. Possession of documents is suspicious. The companion may hold the patient's identification, passport, visa, or insurance documents and refuse to give them to the patient or staff. An inappropriate relationship may be apparent. The age difference or dynamic between the patient and companion may seem unusual or inappropriate, such as a much older boyfriend with a teenage girl. To summarize the key indicators, let me walk you through what to look for across the different categories. For physical indicators, be alert for unexplained injuries or injuries inconsistent with the story provided. Bruises in various stages of healing, burns, cuts, or fractures, signs of sexual assault or genital and rectal trauma, multiple or recurrent sexually transmitted infections, pregnancies, or abortions, branding tattoos such as names, symbols, or barcodes, malnourishment, dehydration, or severe dental neglect, signs of physical restraint such as rope or chain marks, and chronic. For psychological and behavioral indicators, watch for a fearful, anxious, depressed, submissive, or hostile demeanor, avoidance of eye contact, and appearing hypervigilant or easily startled, a scripted, vague, or inconsistent history, disorientation to time, date, or location, an inability to provide an address, signs of post-traumatic stress disorder, signs of a substance use disorder, expressions of fear or paranoia about law enforcement, and expressions of loyalty to or defense of a person who seems. For controlling companion indicators, look for someone who insists on speaking for the patient or being present at all times, refuses to allow the patient to be interviewed alone, holds the patient's identification, money, or phone, a patient who defers to the companion before answering questions, a patient who seems fearful or anxious in the companion's presence, a companion whose story contradicts the patient's story, and a relationship that appears domineering, exploitative, or inappropriate. Now we move into Module 3, which covers patient-centered screening and assessment. Identifying potential indicators of human trafficking is the first step. The next is to create a safe opportunity for screening and potential disclosure. This is a delicate and high-stakes interaction that must be handled with skill, empathy, and a deep understanding of the victim's psychological state. A rushed, judgmental, or poorly executed screening can not only fail to identify a victim, but can also increase their sense of fear and isolation, potentially endangering them further. The foundational approach for this interaction is trauma-informed care. Let's discuss the foundational principles of implementing a trauma-informed approach. Trauma-informed care is a service delivery framework that is grounded in an understanding of and responsiveness to the impact of trauma. It emphasizes physical, psychological, and emotional safety for both patients and providers and aims to empower survivors to rebuild a sense of control. This approach is not a specific set of techniques, but rather a philosophical shift in how care is delivered. It assumes that any patient may have a history of trauma and therefore treats everyone with a universal set of precautions. The core principle is a change in perspective from asking "what is wrong with you" to asking "what happened to you." This shift moves the focus from a patient's symptoms and behaviors to the underlying experiences that may be driving them. Adopting a trauma-informed approach in a clinical setting involves integrating 6 key principles into every patient interaction. The first principle is safety. The top priority is to create an environment where the patient feels physically and emotionally safe. This can be achieved through simple actions like explaining every step of a procedure before it happens, asking for permission before touching the patient, ensuring privacy, and maintaining a calm and predictable demeanor. For a trafficking victim who has had all control taken from them, these small acts of respecting their physical autonomy can be profoundly impactful. The second principle is trustworthiness and transparency. Building trust is paramount, especially with a patient who has been systematically betrayed by others. This involves being honest, reliable, and clear in all communication. It is particularly important to be transparent about the limits of confidentiality. For example, before asking sensitive questions, a clinician should explain their role as a mandatory reporter for child abuse, stating clearly what they are required to report and to whom. The third principle is peer support. While not always possible in an acute care setting, connecting patients with peer support services, meaning individuals with lived experience of trafficking or other trauma, can be a powerful part of the recovery process. Knowing that others have survived similar experiences can instill hope and reduce feelings of isolation. The fourth principle is collaboration and mutuality. This principle involves leveling the power differential between the provider and the patient. The clinician and the patient are partners in the patient's care. The patient is recognized as the expert in their own life and experiences. This collaborative spirit helps to restore a sense of agency to the victim. The fifth principle is empowerment, voice, and choice. Trafficking strips victims of their power and voice. A trauma-informed approach seeks to restore it by offering choices whenever possible, no matter how small. Simple questions like asking whether the patient would prefer to sit in this chair or on the exam table, or asking whether it is okay to ask some personal questions now, give the patient a measure of control over the situation. Their input and decisions should be sought and respected. The sixth principle addresses cultural, historical, and gender issues. Providers must be aware of and actively address potential biases and stereotypes. This involves recognizing the impact of cultural, racial, and gender dynamics on the patient's experience and avoiding making assumptions. It requires a commitment to providing culturally sensitive and affirming care. Now let's discuss how to create a safe environment for disclosure. The single most important practical step in screening for human trafficking is to ensure the patient is alone and in a private setting. A victim will not disclose their situation in the presence of their trafficker. Therefore, every effort must be made to separate the patient from any accompanying person. This must be done tactfully and as a matter of routine policy to avoid raising the trafficker's suspicion, which could place the patient in greater danger. There are several strategies for separating a patient from their companion. One approach is citing policy. A calm, firm statement can be effective, such as explaining that it is the facility's policy to speak with all patients alone for a portion of the visit to ensure their privacy, and asking the companion to please wait while you finish your examination. Another approach is using a pretext. Create a reason for the separation that is a normal part of the clinical workflow. For example, you might explain that you need to take the patient back to get a urine sample, x-ray, or blood draw, and that the companion can wait in the room because it should only take a few minutes. A third approach involves other staff. A nurse or medical assistant can be tasked with leading the companion to a different waiting area to fill out some paperwork or get a coffee while the clinician speaks with the patient. If there is a language barrier, it is absolutely critical to use a professional, qualified medical interpreter. A family member, friend, or especially the companion who came with the patient should never be used as an interpreter. A trafficker acting as an interpreter will intentionally mistranslate to maintain control and prevent disclosure. Professional interpreters are bound by codes of ethics and confidentiality and are essential for accurate and safe communication. Now let's review practical screening techniques and validated questions. Once the patient is alone, the goal is to build rapport and create a non-judgmental space. The objective of the first interaction is not necessarily to elicit a full disclosure or to orchestrate a rescue. For many victims, it may take multiple encounters before they feel safe enough to share their story. The immediate goal is to plant a seed of trust, Provide compassionate care for their presenting medical issue, and let them know that help is available if and when they are ready. Instead of directly asking whether someone is being trafficked, which can be frightening and confusing for a victim, it is more effective to use a series of open ended, non judgmental questions that explore the domains of work, living situations, and control. It is often helpful to normalize these questions by using a framing statement first. Here are some examples of framing statements you might use. You could say that because violence and difficult situations are so common in many people's lives, you have started asking all of your patients these questions routinely. Or you might say that you don't know if this applies to the patient, but you are seeing a lot of patients who are in stressful or unsafe work or home situations, so you ask everyone about these topics. Now, let me share some validated screening questions that can help guide the conversation. These questions are adapted from validated tools like the Vera Institute of Justice's Trafficking Victim Identification tool and other expert sources. To explore labor conditions and freedom of movement, you might ask what kind of work the person does, whether they are being paid for their work, and whether they get to keep the money they earn, whether they can leave their job or work situation if they want to, and if not, what they think would happen if they tried to leave. You could also ask whether their working hours are excessively long, and whether they get enough food, water, and breaks. To explore control and coercion, you might ask whether anyone has their identification, like their driver's license or passport, and if so, whether they can get it back whenever they want. You could ask whether they owe money to their employer or the person they live with, and if so, whether they are able to pay it down. You might also ask whether anyone has ever threatened them or their family. To explore potential sex trafficking, you might ask whether the person has ever had to have sex in exchange for things they need, like a place to stay, food, drugs, or money. If the patient is a minor, it is important to ask about their relationships and home life, including whether there is anyone who is making them do things they don't want to do. If a patient answers yes to any of these questions, or if their responses are evasive or fearful, it is important to respond with validating and empowering statements. You might say, "Thank you for sharing that with me. That sounds like a very difficult situation." You might reassure them that what they are going through is not their fault. You can tell them that they are not alone and that there are people who can help. You might also say that help is available, but their safety is the most important thing, and offer to talk about some options if they are interested. There are special considerations for certain populations. When screening a minor, the legal obligation to report any suspicion of abuse, neglect, or exploitation to the Florida Abuse Hotline is paramount. The conversation should be age appropriate, and the primary goal is to assess for their safety. When screening patients with disabilities, be aware that individuals with physical, cognitive, or developmental disabilities are at an increased risk for all forms of exploitation. Communication may need to be adapted, using simple language, visual aids, or involving specialists who are trained to work with these populations. Their vulnerability may be exploited in unique ways, and their ability to articulate their experience may be limited. When there are language barriers, professional interpreters are non-negotiable. Using phone or video interpretation services is a standard and effective practice. The clinician should speak directly to the patient, not the interpreter, to maintain rapport and a patient-centered focus. By combining the principles of trauma-informed care with practical strategies for creating safety and using validated, non-judgmental questions, healthcare professionals can navigate these sensitive conversations effectively and create a crucial opportunity for a victim to connect with help. Now we move into Module 4, which covers the mandatory response, specifically reporting and documentation. Once a healthcare professional suspects that a patient is a victim of human trafficking, a series of critical actions must follow. This response is guided by professional ethics, federal and state laws, and a commitment to the patient's safety and autonomy. Navigating the reporting process requires a clear understanding of the different pathways for minor and adult victims, as each has distinct legal requirements in Florida. Simultaneously, meticulous and objective documentation is essential for ensuring continuity of care and for potential future legal proceedings, all while navigating the complexities of patient confidentiality under HIPAA. Let's begin by discussing your professional and ethical obligations to act. The decision to act on a suspicion of human trafficking is rooted in the fundamental ethical principles of healthcare: beneficence, which means to do good, and non-maleficence, which means to do no harm. A patient in a trafficking situation is experiencing ongoing severe harm. The healthcare professional has an ethical obligation to take reasonable steps to protect that patient and connect them with safety. This ethical duty is reinforced by a legal one. In Florida, as in all states, healthcare professionals are mandatory reporters of child abuse. As human trafficking of a minor is a form of child abuse, this mandate is clear and non-discretionary. While the legal mandate for reporting adult victims is more nuanced, the ethical imperative to offer help to a person in grave danger remains. Now let's navigate the reporting pathways. It is critically important for Florida healthcare professionals to understand that there are distinct and separate reporting pathways for suspected minor victims and adult victims. Using the wrong pathway can fail to trigger the appropriate protective response and may place the provider in legal jeopardy for failing to meet their mandatory reporting obligations. First, let me discuss the National Human Trafficking Hotline, which is a resource for reporting all suspected cases. This is a 24-hour, 7 days a week, confidential, multilingual resource operated by the nonprofit organization Polaris. It serves as a central point of contact for the entire country. The phone number is 1-888-373-7888. You can also text the word HELP or the word BEFREE to 233733. There is also a website with live chat available at humantraffickinghotline.org. The National Human Trafficking Hotline has two primary functions. The first is service provision. Hotline advocates can connect victims and survivors directly with a nationwide network of vetted service providers, offering resources for emergency shelter, legal AID, mental health counseling, and more. The second function is tip reporting. The hotline can receive tips about suspected trafficking situations from the public and professionals. After assessing the tip, advocates will relay the information to specialized federal, state, or local law enforcement task forces for investigation. For a competent adult patient who you suspect is being trafficked, the National Human Trafficking Hotline is the primary and most appropriate resource to call. This approach respects the adult's autonomy. You can offer to make the call with the patient, provide them with the number, or, with their consent, make the call on their behalf. This connects them to a system specifically designed to provide victim-centered assistance. Now let me discuss Florida's mandatory reporting law for suspected child trafficking, which requires reporting to the Florida Abuse Hotline, which is operated by the Department of Children and Families, or DCF. The legal requirement for reporting suspected child trafficking in Florida is unambiguous. Under Florida Statute Chapter 39, any person, including a healthcare professional, who knows or has reasonable cause to suspect that a child is being abused, abandoned, or neglected, must report it to DCF. Human trafficking of a minor, whether for sex or labor, falls under this definition of abuse and exploitation. The required reporting channel is the Florida Abuse Hotline. The phone number is 1-800-962-2873. There is also a website available at myfl-families.com. This is a critical point. A report to the National Human Trafficking Hotline about a minor victim does not satisfy a healthcare professional's mandatory reporting duty under Florida law. The report must be made to the Florida Abuse Hotline. Failure to do so can result in professional disciplinary action and legal penalties. Upon receiving a report, the hotline will screen the information and, if accepted, dispatch a child protective investigator, often in coordination with law enforcement, to assess the child's safety and initiate a protective investigation. In addition to these two primary hotlines, Florida also operates a statewide toll-free number managed by the Florida Department of Law Enforcement, or FDLE, specifically for human trafficking tips. That number is 1-855-FLACIF, which is 1-855-352-7233. This number can be used to report information directly to state law enforcement authorities. The decision-making process for reporting can be simplified into two questions. First, Is the suspected victim under the age of 18? If yes, you must call the Florida Abuse Hotline at 1-800-96-ABUSE. Second, is the suspected victim an adult? If yes, the best first step is to engage the patient, if it is safe to do so, and connect them with the National Human Trafficking Hotline at 1-888-373-7888. Now let's discuss best practices for clinical documentation. Documentation in the patient's medical record is a critical component of the response. The record serves as a legal document, ensures continuity of care, and can be vital evidence if the survivor chooses to pursue legal action in the future. Documentation must be objective, factual, and non-judgmental. Maintaining objectivity and factual detail is essential. The goal is to document observations, not to render a legal judgment. Avoid conclusory labels like victim of human trafficking in the primary diagnosis. Instead, describe the facts that led to your suspicion. Use direct quotes whenever possible. Record the patient's own words using quotation marks. For example, instead of writing that the patient is controlled by her boyfriend, document that the patient states, "My boyfriend holds my passport and tells me I cannot leave the apartment without him." Describe physical findings in detail. Document all physical injuries with precision. Note the location, size, shape, and color of bruises, burns, or other wounds. Use a body map if available. Detail your behavioral observations. Record the patient's demeanor and behavior objectively. For example, you might note that the patient avoided eye contact throughout the interview, spoke in a quiet tone, and frequently looked toward the door. Document your actions. Record the steps you took, such as noting that the patient was interviewed alone after the companion was asked to wait in the lobby, that the patient was provided with the National Human Trafficking Hotline number on a small card, and that a social work consult was placed. Photographic evidence can be powerful, but photographs must be obtained with the patient's full, informed, and written consent. Explain to the patient why you are recommending photos, which is to document their injuries for their medical record, how they will be stored, and who can access them. The consent form should be scanned into the medical record along with the labeled photographs. When taking photos, include a ruler for scale and take pictures from various angles, including a full body shot to link the injuries to the patient. Healthcare professionals are rightly concerned about patient privacy, but HIPAA is not a barrier to reporting suspected abuse when required by law. The HIPAA privacy rule explicitly permits a covered entity to disclose protected health information without the patient's authorization in certain situations. For reporting child abuse, the rule allows for the disclosure of protected health information to a public health authority or other appropriate government agency authorized by law to receive reports of child abuse or neglect. Therefore, reporting suspected child trafficking to the Florida Abuse Hotline, which is DCF, is a permitted disclosure under HIPAA. For reporting adult abuse and averting threats to safety, HIPAA permits disclosure if it is necessary to prevent or lessen a serious and imminent threat to the health or safety of a person or the public. If you believe an adult patient is in immediate danger, you are permitted to disclose necessary information to law enforcement or others who can prevent the threat. Respecting adult autonomy is also important. In non-imminent situations involving a competent adult, the ethical standard is to empower the patient. The goal should be to obtain the patient's consent before making a report to the National Human Trafficking Hotline or law enforcement. A patient may refuse help, and unless they are a minor or there is an imminent threat, their decision must be respected. However, you should still document your assessment and the resources you offered. The goal is to create a safe and trusting relationship so that the patient feels comfortable returning for care and may be ready to accept help in the future. By following these guidelines for reporting and documentation, healthcare professionals can fulfill their legal and ethical duties while prioritizing the safety and well-being of the patient. Now we move into Module 5, which covers connecting victims to care through resources and referrals in Florida. Identifying and reporting human trafficking is a critical intervention, but it is only the first step on a long and difficult path to recovery for survivors. The trauma of exploitation leaves deep and lasting wounds, whether physical, psychological, or emotional. To heal, survivors require a comprehensive and coordinated continuum of care that addresses their complex needs. Healthcare professionals play a vital role not only in providing immediate medical treatment, but also in serving as a bridge, connecting survivors to the network of public and private services that can support their long-term recovery. Let's discuss the continuum of care and the key services survivors need. Recovery from human trafficking is not a linear process and requires a holistic, multidisciplinary approach. Survivors often face a cascade of interconnected challenges that must be addressed simultaneously. While every survivor's journey is unique, the core service needs generally fall into several key categories. Emergency services and safe housing are often the most immediate needs. A survivor's most immediate need upon leaving a trafficking situation is safety. This includes emergency shelter or a safe house that can provide a secure, confidential location away from the trafficker. Stable, long-term housing is one of the most critical factors in preventing re-victimization. Comprehensive medical care is essential. Beyond treating acute injuries, survivors need comprehensive health care to address the long-term consequences of neglect and abuse. This includes primary care, dental services, treatment for chronic conditions, and specialized reproductive and sexual health services. Mental health and substance use treatment are critical components of recovery. The psychological trauma of trafficking is severe and often manifests as PTSD, depression, anxiety disorders, and substance use disorders. Access to trauma-informed mental health counseling and addiction treatment is essential for healing. Legal AID and immigration services are often needed. Survivors may need legal assistance for a variety of issues, including vacating criminal records for offenses they were forced to commit, such as prostitution, obtaining restraining orders against their traffickers, and family law matters. For foreign national victims, specialized immigration legal services are crucial for obtaining a T visa or other legal status that allows them to remain in the United States and rebuild their lives. Case management and victim advocacy help navigate the system. Navigating the complex web of social services, legal systems, and healthcare can be overwhelming. A dedicated case manager or victim advocate can help a survivor develop a recovery plan, access services, and provide emotional support throughout the process. Education and economic empowerment support long-term independence. To achieve long-term independence and stability, survivors often need access to educational programs, vocational training, and job placement services. Now let me review the national and Florida-based resources available for victims. A network of governmental and nonprofit organizations at both the national and state level provides services to trafficking survivors. At the national level, the National Human Trafficking Hotline at 1-888-373-7888 is the primary national hub. In addition to taking tips, its most important function is its National Referral Directory, a database of thousands of vetted service providers across the country. A call to the hotline can connect a survivor with local resources tailored to their specific needs. The National Center for Missing and Exploited Children at 1-800-THA-LOST is a critical resource for cases involving child trafficking, providing support to families and law enforcement in the recovery and identification of missing children. The U.S. Department of Health and Human Services Office on Trafficking in Persons funds a wide range of victim service programs throughout the country and provides resources and training through campaigns like SOAR, which stands for Stop, Observe, Ask, Respond. At the Florida level, several key resources are available. The Florida Department of Children and Families, or DCF, is the lead state agency for minor victims. It is responsible for all child protective investigations and provides services to commercially sexually exploited children. DCF licenses and oversees a statewide network of specialized safe houses and safe foster homes, designed to provide trauma-informed care to minor survivors of sex trafficking. The Florida Attorney General's office plays a central role in the state's anti-trafficking efforts. The statewide Council on Human Trafficking, chaired by the Attorney General, brings together law enforcement, prosecutors, legislators, and service providers to coordinate the state's response and develop policy recommendations. The Division of Victim Services administers the state's Crime Victim Compensation Fund, which can help innocent victims of crime, including trafficking survivors, with financial assistance for medical bills, lost wages, and mental health services. The toll-free number for this division is 1-800-226-6667. The Florida Alliance to End Human Trafficking was created by the Florida legislature and works to provide training and awareness across the state and serves as a hub for information and resources. Local human trafficking task forces exist in many regions of Florida. These are multidisciplinary task forces that bring together law enforcement, prosecutors, and victim service organizations to coordinate a local response. These task forces are often the best source for referrals to direct service providers in a specific community, such as those in Miami-Dade and Broward counties. A wide range of nonprofit direct service providers across Florida provide direct services, including emergency shelter, transitional housing, legal AID, and mental health counseling. The best way to locate a vetted provider in a specific area is by contacting the National Human Trafficking Hotline or a local task force. It is important to acknowledge that while Florida has made significant strides in building a response to human trafficking, significant gaps in the service continuum remain. Healthcare professionals should be aware that a referral does not always guarantee immediate access to care. Understanding these challenges can help manage patient expectations and reinforce the need for persistent advocacy on their behalf. Research and reports from stakeholders in Florida have identified several key areas of need. There is a critical shortage of housing for survivors, particularly for adult survivors. While DCF has a certification process for minor safe houses, no such standardized system exists for adult housing, leading to a lack of oversight and capacity. It is estimated that up to 80% of survivors may be re-victimized if they do not have a safe place to live. There is a statewide need for more accessible, affordable, and trauma-informed mental health services for survivors. The complex psychological needs of this population often require specialized treatment that is not widely available. Access to free or low-cost legal services, especially for the complex process of vacating criminal records or obtaining immigration relief, is limited in many parts of the state. Resources and public awareness have historically focused more on sex trafficking. As a result, there are fewer specialized services available for the large population of labor trafficking survivors. Service providers in Florida have noted the urgent need for a more centralized and standardized service referral mechanism to improve coordination and ensure survivors can efficiently connect with the help they need. By understanding both the available resources and the existing system-level challenges, healthcare professionals can be more effective advocates for their patients, helping them navigate a complex landscape on their path to recovery. Let me now conclude this course by summarizing the key points and reaffirming your role in restoring freedom and health to trafficking victims. The crime of human trafficking is a deeply entrenched and complex crisis in Florida, affecting hundreds of thousands of individuals hidden within our communities. The scale of the problem can feel overwhelming, yet the power to effect change often lies in a single, informed, and compassionate interaction. As this course is detailed, the healthcare setting is a unique and critical intersection point where victims of modern-day slavery can find a potential lifeline to freedom. The key takeaways are practical and actionable. Understanding the fundamental dynamics of force, fraud, and coercion allows a clinician to see beyond the common myths of kidnapping and recognize the subtle but powerful psychological chains that bind victims. Being equipped to identify the clinical indicators, including the patterns of physical injury, psychological trauma, and behavioral red flags, transforms a routine examination into an opportunity for life-saving intervention. Implementing a trauma-informed approach is not just best practice. It is the essential foundation for creating a safe space where a terrified and manipulated individual might feel secure enough to accept help. Navigating the mandatory response is a professional duty that requires precision. For suspected victims under 18, the path is clear and non-negotiable. A report to the Florida Abuse Hotline at 1-800-96-abuse. For adult victims, the National Human Trafficking Hotline at 1-888-373-7888 is the primary gateway to a national network of specialized services, a resource that respects the victim's autonomy while offering a pathway to safety. Meticulous, objective documentation serves both the patient's immediate care and their potential future pursuit of justice. Finally, knowing the landscape of victim resources in Florida, while also understanding its gaps, enables the healthcare professional to be a realistic and effective advocate. As a final, tangible step in compliance with Florida law and in support of this cause, Florida Statute 456.0341 requires that licensees post a sign in a conspicuous place accessible to employees. The sign must be at least 11 by 15 inches with 32-point type and state the following in both English and Spanish. If you or someone you know is being forced to engage in an activity and cannot leave, whether it is prostitution, housework, farm work, factory work, retail work, restaurant work, or any other activity, call the Florida Human Trafficking Hotline 1-855-SFLA-SAFE to access help and services. Victims of slavery and human trafficking are protected under United States and Florida law. Your role as a healthcare professional extends beyond diagnosing illness and treating injury. You are a trusted member of the community, uniquely positioned to see the unseen and give voice to the silenced. By integrating the knowledge from this course into your daily practice, you become a vigilant and indispensable partner in the fight against human trafficking, offering hope, healing, and the first step toward a restored life. This concludes the continuing education course on human trafficking for Florida healthcare professionals. Welcome to Module 6 of our continuing education course on human trafficking. This is where we bring everything together. In the preceding modules, you've built a comprehensive foundation of knowledge regarding human trafficking, including its definitions, dynamics, clinical indicators, trauma-informed approaches, reporting requirements, and available resources. Now, this final module is designed to bridge the gap between that theoretical understanding and practical application. Through 6 detailed clinical scenarios, you will be challenged to synthesize the information you have learned and apply it to realistic situations you may encounter in your professional practice. Each case study presents a unique patient encounter across a variety of healthcare settings common in Florida, including emergency departments, community health clinics, pharmacies, pediatric offices, and urgent care centers. The cases represent the diverse manifestations of human trafficking, encompassing sex trafficking of both minors and adults, labor trafficking in industries prevalent in Florida such as agriculture and domestic servitude. The victims portrayed reflect the demographic reality of this crisis, spanning different ages, genders, nationalities, and socioeconomic backgrounds. For each case, I will present a clinical scenario followed by a detailed analysis that integrates the core concepts from this course. Approach these cases as you would a real patient encounter, with careful observation, clinical curiosity, professional skepticism, and above all, compassion. Remember that the goal is not to make a definitive determination of trafficking status, as that is the role of law enforcement investigators. Rather, your role is to recognize concerning patterns, respond in a safe and patient-centered manner, and ensure the patient is connected to the appropriate resources and protective systems. Let's begin with our first case study, which takes place in an emergency department setting. Picture yourself as the triage nurse in a busy Level 2 trauma center in Tampa, Florida. It is 11:47 p.m. on a Friday night when EMS brings in a 15-year-old female patient, registered as Destiny, with a chief complaint of abdominal pain. The paramedics report that they were called to a motel on the outskirts of Tampa after a 911 call from an anonymous male caller who stated a girl was sick and then hung up. When they arrived, the patient was found alone in the room, sitting on the edge of the bed, and the room showed signs of recent occupancy by multiple people, including numerous used condoms in the trash can. Upon initial assessment, Destiny is dressed in revealing clothing that appears too large for her thin frame. She avoids eye contact and answers your questions in monosyllables. Her vital signs are stable, but her heart rate is elevated at 102 beats per minute. She winces when you palpate her lower abdomen. You note faint yellowish bruising on her inner upper arms bilaterally, consistent with grip marks approximately 5 to 7 days old. On her left inner forearm, you observe a small, amateur-looking tattoo that reads Daddy's in cursive script. The tattoo appears relatively fresh, with slight redness at the edges. When you ask if there is a parent or guardian you can contact, Destiny becomes visibly agitated and says quickly, "No, don't call anyone. My boyfriend will be here soon. He takes care of me." She repeatedly glances at the door. When you ask how old her boyfriend is, she hesitates and says, "He's older, like 20 something. I don't know exactly." Approximately 20 minutes later, a man who appears to be in his late 20s arrives and identifies himself as Marcus, Destiny's guardian. He is well dressed, wears expensive jewelry, and speaks in a calm, controlled manner. He immediately positions himself close to Destiny's bed and places his hand on her shoulder. You notice Destiny's body language change. She becomes even more withdrawn and her eyes stay fixed on the floor. Marcus speaks. "Look, she just has some stomach issues. She probably ate something bad. We don't need all these tests. Can you just give her some medicine so we can go? I've got things to handle tonight." When you explain that you need to speak with the patient privately, as a matter of standard hospital policy, Marcus's demeanor shifts slightly. His jaw tightens and he says, "That's not necessary. She doesn't talk much anyway. She's a little slow. I speak for her. She's my responsibility." Now let's analyze this case in detail, starting with the identification of red flags. This scenario is saturated with indicators of commercial sexual exploitation of a child, which is a form of sex trafficking. The red flags are numerous and compelling. First, consider the location and circumstances of discovery. A motel, with the patient found alone after a call from an anonymous male, with evidence of sexual activity in the room. Motels are common venues for sex trafficking operations. Second, the patient's age of 15 years combined with these circumstances is deeply concerning. Third, she is wearing inappropriate and ill-fitting clothing. Fourth, her physical presentation, including avoidance of eye contact, withdrawn demeanor, and monosyllabic responses, suggests fear, shame, or coaching by a trafficker. Fifth, there are physical findings of abuse. The grip mark bruising on her inner arms is a classic finding of physical assault and restraint. Sixth, and this is exceptionally significant, is the branding tattoo reading Daddy's. The term daddy is common vernacular in sex trafficking for a pimp, and the tattoo signifies ownership. This is a high specificity indicator. Seventh, the patient exhibits anxiety about contacting a parent and makes statements that her boyfriend will take care of her. Eighth, there is a significant age discrepancy between this 15-year-old and her 20-something boyfriend, which represents a classic lover boy or Romeo pimp dynamic. Ninth, we have the arrival of Marcus, a controlling companion who answers for the patient, attempts to minimize her medical complaints, and pressures for a quick discharge. And 10th, Marcus attempts to block private communication between the patient and clinical staff by claiming she is slow and that he speaks for her. The legal significance of Destiny's age cannot be overstated. She is 15 years old, which is below the age of 18. Under both federal law, specifically the Trafficking Victims Protection Act and Florida law, any minor induced to perform a commercial sex act is a victim of sex trafficking by definition, regardless of whether force, fraud, or coercion can be proven. The means element of the action means purpose model does not need to be established for a minor. The law recognizes that a child cannot consent to commercial sex. Therefore, the evidence suggesting Destiny is being commercially sexually exploited, including the motel setting, the condoms, and the branding tattoo, is sufficient to raise a high index of suspicion for trafficking without needing to prove she is being forced. When it comes to the trauma-informed approach, once Destiny is separated from Marcus, which is a non-negotiable priority, the approach must prioritize her sense of safety and autonomy. Specific strategies include ensuring physical safety and privacy by moving to a quiet room, closing the door, and assuring her she is safe in the hospital. Use a calm, non-judgmental tone and validate her experience by saying things like, "I'm not here to get you in trouble. I'm here to help you." Offer choices to restore a sense of control, such as, "Would you like some water? Is it okay if I sit here?" Explain what will happen next with transparency, being honest about the limits of confidentiality. Avoid direct accusatory questions about trafficking. Instead, use open ended, validated screening questions about her living situation, work, and relationships. If she is not ready to talk, respect that boundary and simply provide compassionate medical care for her presenting complaint while ensuring she knows help is available. Regarding mandatory reporting obligations, this case involves a suspected minor victim of abuse and exploitation. Under Florida Statute Chapter 39, the nurse has a clear, non discretionary legal duty to report this suspicion. The report must be made to the Florida Abuse Hotline, operated by the Department of Children and Families, at 1 800 96 abuse, which is 1 800 962 2873. A call to the National Human Trafficking Hotline, while a valuable resource, does not satisfy the legal mandate to report suspected child abuse to DCF. The hospital's social work team should also be immediately involved. Documentation in this case must be objective and factual, avoiding legal conclusions. Examples of appropriate documentation include: patient is a 15-year-old female brought in by EMS from the specific motel name, where she was found alone. EMS reports presence of used condoms in the room. Patient observed wearing clothing that appears several sizes too large. Noted faint, yellowish ecchymosis measuring approximately 4 centimeters by 2 centimeters on bilateral inner upper arms, consistent with healing contusions approximately 5 to 7 days old. Observed tattoo on left inner forearm reading Daddy's is in cursive script. Edges appear mildly erythematous. Patient stated, "My boyfriend will be here soon. He takes care of me." Cause when asked the boyfriend's age, patient stated, "She's older, like 20-something. Adult male, self-identified as Marcus, arrived at the specific time and stated he is patient's guardian. Marcus declined provider's request to speak with patient privately, stating, "She's a little slow. I speak for her." 2. To concerns for patient safety based on physical findings and circumstances of presentation, Florida Abuse Hotline contacted at specific time. Report number documented. Now let's move to our second case study, which illustrates labor trafficking in the agricultural sector. You are a nurse practitioner at a federally qualified health center serving agricultural communities in Immokalee, Florida. A 34-year-old male patient named Miguel presents with a chief complaint of severe back pain and a persistent, productive cough. He is accompanied by another man named Javier, who identifies himself as Miguel's crew leader and states he drove Miguel to the clinic because he needs to get better and get back to work. Miguel appears significantly older than his stated age. He is gaunt, with sunken cheeks, cracked lips, and deeply tanned, weathered skin. His clothes are stained and torn. He has difficulty making eye contact and seems hesitant to speak. When you ask questions, he often looks to Javier before answering. A qualified medical interpreter is available via phone, and you insist on using this service despite Javier's offer to translate, "since I know what he needs." Using the interpreter, you learn that Miguel has been working in the tomato fields for the past 8 months. When you ask about his living situation, he says he and about 15 other men live in a single wide trailer on the farm property. He states they are charged $50 per week each for rent and fees, which is deducted from their pay. When you ask how much he earns, he becomes quiet and says, "I don't know exactly." Javier handles the money. "We will get paid at the end of the season, after our debts are paid." When asked about the debts, he explains he owed money for his transportation to Florida from Guatemala and for supplies he was given when he arrived. On physical exam, you note multiple healing lacerations and abrasions on his hands consistent with agricultural work, along with significant muscle wasting. His cough is productive of greenish sputum. You also observe a long, linear, raised scar on his upper back. When you ask about it through the interpreter, Miguel becomes visibly distressed. He looks at the closed exam room door and whispers, "Please, I cannot talk about that. I just need medicine for my cough." Javier is waiting. "If I am not back to work tomorrow, there will be problems." Let's analyze this case, starting with the type of trafficking involved. This scenario strongly suggests labor trafficking in the agricultural sector. Applying the action means purpose model, the action is harboring and obtaining Miguel for labor. The means appear to include fraud, likely through false promises about pay and conditions, coercion through debt bondage, threats of problems, psychological manipulation, and control over wages, and potentially force, as suggested by the unexplained scar on his back and his fear and distress. The purpose is exploitation for involuntary servitude in the agricultural fields. All three elements of the AMP model appear to be present for this adult victim. The decision to insist on using a qualified medical interpreter was one of the most critical clinical decisions in this encounter. Using Javier, the crew leader, as an interpreter would have been dangerous for multiple reasons. Javier is the potential trafficker or an agent of the trafficker. He would have complete control over the communication, able to manipulate questions and censor Miguel's answers. Miguel would have had no opportunity for confidential disclosure, as anything he said would be immediately known to his controller. Using the trafficker as an interpreter could increase danger to the patient after the visit. A qualified medical interpreter is bound by professional ethics and confidentiality, ensuring accurate communication and creating a safer space for the patient. The reporting obligations in this case differ significantly from the first case involving a minor. Unlike that situation, there is no automatic mandatory reporting duty under Florida law for suspected trafficking of a competent adult. Miguel is an adult who has not explicitly asked for help and has expressed fear about the consequences of leaving. The ethical approach here centers on patient autonomy and a harm reduction model. The clinician's role is to provide compassionate medical care, plant a seed of trust, provide information about available resources, and empower Miguel to make his own choices when he is ready. However, if the clinician believes there is a serious and imminent threat to Miguel's life, disclosure to law enforcement may be permissible under HIPAA. The primary resource to offer Miguel is the National Human Trafficking Hotline at 1-888-373-7888, which can provide him with support and connect him with specialized services. Information can be provided discreetly. Several mechanisms of control are evident in this case. Debt bondage is present as Miguel states he owes money for transportation and supplies, and his pay is withheld to cover these debts. This is a classic debt bondage scheme where the debt is designed to be unpayable, trapping the worker indefinitely. Wage theft and economic control are apparent because Javier handles the money, and Miguel does not know his actual earnings. Wages are promised at the end of the season, a common tactic to prevent workers from leaving. Isolation is a factor because Miguel lives on the property controlled by the employer in overcrowded conditions with no independent transportation. Threats and intimidation are suggested by Miguel's fear of problems if he doesn't return to work, and physical force is strongly suggested by the unexplained scar on his back and his distressed reaction when asked about it. The immediate clinical priority is to address Miguel's presenting medical conditions, evaluating and treating his back pain and his productive cough, which warrants workup for respiratory infection or other pulmonary pathology. Regarding trafficking, the approach must be patient-centered. Even if Miguel is not ready to leave today, the clinician should treat him with dignity and compassion, acknowledging the difficulty of his situation without judgment. The clinician should provide information about his rights as a worker and about services available. This can be done discreetly, such as by writing the NHTH number on a prescription pad or a small card that he can hide. The clinician should use empowering statements such as, "What is happening to you is not right. You deserve to be paid for your work. There are people who can help when you are ready." The clinician should ensure Miguel knows the clinic is a safe place he can return to. The goal is to build trust and keep the door open for future engagement. Our third case study presents a particularly insidious form of labor trafficking, domestic servitude. You are a nurse at an urgent care clinic in an affluent neighborhood in Naples, Florida. A well-dressed woman in her 50s, Mrs. Harrington, brings in a younger woman named Maria, who she introduces as her live-in housekeeper. Mrs. Harrington states Maria has had a bad cough for several weeks and she finally had time to bring her in. Maria appears to be in her late 20s or early 30s. She is dressed in plain, worn clothes that contrast sharply with Mrs. Harrington's designer attire. Maria is thin and pale, with dark circles under her eyes. She keeps her gaze lowered and stands slightly behind Mrs. Harrington. When you ask Maria directly how she is feeling, Mrs. Harrington answers for her. She doesn't speak much English. I'll translate. She's fine, just the cough. You explain clinic policy regarding private patient interviews, and, after some resistance from Mrs. Harrington, who says this is really unnecessary because Maria is quite shy, you escort Maria to an exam room alone. Using a Spanish language telephone interpreter, you learn a very different story. Maria tells you she came from Honduras 3 years ago. An agency connected her with the Harrington family, promising good wages as a nanny and housekeeper. Upon arrival, her passport and phone were taken. She works from 5 in the morning until after midnight every day, cooking, cleaning, caring for 3 children, and doing laundry. She sleeps on a cot in the laundry room. She is given food when there are leftovers. She has never been paid. When she asked about her wages, Mr. Harrington told her she was working off her debt for the agency fee and her room and board, and that if she tried to leave or complain, he would report her to immigration. Maria states she has not left the house alone in over 2 years. This is the first time she has seen a doctor. She mentions she has pain in her hands from all the cleaning and sometimes feels dizzy. She whispers, "I am so tired. I just want to go home to my mother. But I have no money, no papers. I am trapped." Let's analyze this case carefully. Maria is a victim of domestic servitude, a particularly insidious form of labor trafficking. In domestic servitude, victims are forced to work in private households, often as nannies, housekeepers, or caregivers. This form of trafficking is uniquely difficult to identify because the exploitation occurs behind the closed doors of a private residence, completely hidden from public view. There are no co-workers to witness the abuse, no labor inspectors with access, and the victim is entirely isolated within the trafficker's home. The trafficker is simultaneously the employer and the captor, controlling every aspect of the victim's life. Maria's urgent care visit represents a rare and critical point of potential intervention. The Harringtons employ a comprehensive system of control. Fraud was used to lure Maria with a false promise of a legitimate, paid job. Document confiscation is evident in that her passport and phone were taken, stripping her of identity and communication. Debt bondage is present because she is told she is working off an ever-present debt for agency fees and room and board, ensuring she can never earn her freedom. Wage theft is clear since she has not been paid in 3 years. Threats and coercion are present through the threat of reporting her to immigration, which exploits her undocumented status. Isolation is extreme, as she has not left the house alone in 2 years and has no contact with the outside world. Physical deprivation is evident through inadequate food, inadequate rest from sleeping on a cot in the laundry room, and being worked from 5 in the morning until past midnight. Psychological control is apparent in that she describes feeling trapped and hopeless. This case is a powerful illustration that traffickers do not fit a single profile. Mrs. Harrington is a well-dressed, affluent woman living in a wealthy neighborhood who presented herself as a concerned employer. Traffickers can be anyone, men or women, wealthy or poor, business owners, family members, or romantic partners. Healthcare professionals must not let the socioeconomic status, appearance, or demeanor of a patient's companion lower their index of suspicion. The focus must always be on the indicators presented by the patient themselves, particularly those revealed when the patient is interviewed alone. Maria has made a disclosure and expressed a desire for help. This is a critical moment. The clinician should validate her experience and express empathy by saying things like, "What is happening to you is wrong. You are not at fault. There are people who can help you." The clinician should assess her immediate wishes. Does she want to leave the Harrington house now, or does she need time to consider her options? If she is ready for immediate help, the clinician should engage the clinic's social worker or call the National Human Trafficking Hotline at 1-888-373-7888 immediately to begin coordinating a safety plan, which may involve contacting law enforcement. If she is not ready to leave immediately, the clinician should provide her with the NHTH number discreetly, perhaps written inside a bandage box or on a small piece of paper she can hide. The clinician should emphasize that this is a confidential resource she can call when she is ready, 24 hours a day, 7 days a week. The NHTH can connect her with organizations that provide emergency shelter, legal AID, including immigration assistance for the Tavisa, and case management. If Maria returns to the Harrington home, her safety is a concern. Before she leaves, the clinician should ensure all documentation is objective and does not explicitly accuse the Harringtons in a way that could put Maria at risk if records were somehow accessed. The clinician should discuss with Maria whether it is safe for her to keep any written information like a hotline number. If not, encourage her to memorize the number. Let her know the clinic is a safe place and she can return. If possible, schedule a follow-up appointment for her cough, which provides a legitimate reason for her to return to the clinic and another opportunity for intervention. The goal is to keep the door open while respecting her autonomy and timeline. Our fourth case study takes us to an unexpected setting, a community pharmacy. You are a pharmacist at a busy retail pharmacy in Jacksonville, Florida. You have worked at this location for 5 years and know many of your regular customers. One of them is Ashley, a 19-year-old woman you have known since she was a teenager picking up prescriptions for her grandmother. Ashley has a history of anxiety and depression and has filled prescriptions for Lexapro at your pharmacy for years. Over the past 6 months, you have noticed significant changes in Ashley. She used to come in alone, chatty, and friendly. Now, she is always accompanied by a man named Darnell, who appears to be in his mid-30s. Ashley's appearance has changed dramatically. She has lost a considerable amount of weight, her hair is often unkempt, and she wears heavy makeup that doesn't quite conceal dark circles under her eyes. She no longer makes small talk and avoids eye contact. Today, Ashley presents a new prescription from an unfamiliar prescriber at a clinic across town, not her usual provider. The prescription is for oxycodone 30 milligrams, quantity 60. Darnell stands close behind her at the counter. When you ask Ashley if she has a new doctor, she hesitates. Darnell steps forward and says, "Yeah, she heard her back at work. New job, you know. Just fill it." You ask Ashley directly, "Is everything okay? You seem different lately." Before she can respond, Darnell puts his arm tightly around her shoulder and says with a tight smile, "She's fine. We're in a hurry. She's got to get to work." Ashley's eyes meet yours for just a moment, and you see something in them. Fear, a plea. Before she looks away and murmurs, "I'm fine. Just fill it, please." While processing the prescription, you pull up her pharmacy profile and notice several concerning patterns over the past few months. Multiple prescriptions for Plan B, the emergency contraception, filled in short succession, a prescription for azithromycin, which is commonly used to treat chlamydia, and her long-standing Lexapro prescription has not been refilled in 3 months. Let's examine what this case reveals. Ashley's transformation over 6 months presents a textbook cluster of red flags. She has gone from independent and friendly to withdrawn, and always accompanied by a controlling older man. She has experienced significant weight loss, poor self-care, and signs of exhaustion. Her change in demeanor, including avoiding eye contact and no longer engaging in conversation, suggests fear, depression, or coaching by a trafficker. The brief moment of eye contact with the pharmacist, described as a plea, is a critical nonverbal signal that her stated "I'm fine" may not be true. These changes, taken together, strongly suggest she has entered a controlling and potentially exploitative relationship. The prescription history tells a compelling story. Multiple prescriptions for Plan B in short succession suggests frequent unprotected sex, which could indicate commercial sexual exploitation. The azithromycin prescription points to a recent sexually transmitted infection, consistent with the risk profile of sex trafficking. The discontinuation of her Lexapro is concerning. A person with a history of anxiety and depression stopping their psychiatric medication may indicate loss of access to her regular healthcare provider, inability to manage her own care, or control by another person over her health decisions. Finally, the new opioid prescription from an unfamiliar provider is a major red flag. Traffickers often use opioids to control victims by creating or fueling addiction, making them dependent on the trafficker as the source of the drug. This prescription may be intended for Ashley's use as a control mechanism, or it may even be intended for diversion. Darnell displays multiple hallmark behaviors of a controlling companion. He is always present when Ashley comes to the pharmacy. He speaks for her, answering questions directed at her. He positions himself physically close to her, with his arm tightly around her shoulder. He is dismissive of the pharmacist's concern by saying she's fine and pressures for a quick transaction. He cuts off Ashley's opportunity to respond to a direct question about her well-being. His demeanor shifts to a tight smile when challenged, suggesting controlled aggression. And his reference to her needing to get to work, combined with the other indicators, is suspicious. The pharmacist is in a unique position in the healthcare system, often seeing patients more frequently than physicians. Options include creating an opportunity for private conversation by asking Ashley to step to a private counseling window to discuss the new medication, separating her from Darnell. The pharmacist could provide discrete information by writing the NHTH number on a pharmacy bag, on the back of a prescription printout, or slipping a small card with resources. If alone with Ashley, the pharmacist could ask direct but gentle questions such as, "Are you safe? Is anyone hurting you or making you do things you don't want to do?" If concerns about the opioid prescription exist, such as a suspicious prescriber or potential doctor shopping, the pharmacist can use their professional judgment to decline to fill it or to contact the prescriber. The pharmacist can also document concerns in the pharmacy system. However, there are limitations. The pharmacist cannot force Ashley to accept help. As an adult, her autonomy must be respected. The pharmacist is not a mandatory reporter for adult trafficking in the same way as for child abuse, but ethical obligations to patient welfare remain. The tension between respecting Ashley's stated wishes and the concern for her safety is an ethical challenge inherent in working with potential adult trafficking victims. Ashley has stated she is fine. However, her nonverbal communication and the pattern of evidence suggest otherwise. A victim's initial denial is common due to fear, trauma bonding, or direct coaching by a trafficker. The pharmacist's role is not to override Ashley's autonomy, but to create a safe opening and plant a seed. The pharmacist can say something like, "Okay, Ashley, I'm always here if you need to talk. Here's some information that goes with your medication." The goal is to convey care, demonstrate that a trusted person has noticed, and provide an escape route through the NHTH number for when and if Ashley is ready to take it. The door should always remain open. Our fifth case study involves a particularly vulnerable population, foster youth. You are a school nurse at a high school with an on-site health clinic in Miami, Florida. A 16-year-old female student named Brianna is referred to you by her guidance counselor because of chronic absences and falling asleep in class. The counselor mentions that Brianna is in foster care and has had multiple placements in the past 2 years. Brianna presents as guarded and initially dismissive, saying she's fine and just tired. She is wearing an expensive-looking bracelet that seems incongruous with her otherwise modest appearance. Upon gentle, non-judgmental questioning in a private setting, Brianna slowly begins to open up. She tells you she met a guy named Terrence on Instagram about 4 months ago. He's 24 and told her she was beautiful and special. He bought her gifts, including the bracelet, a new phone, and clothes. He told her he loved her and that he would take care of her, unlike her foster families. She started sneaking out at night to see him. He introduced her to some of his friends. Brianna's demeanor shifts as she continues. She becomes quieter and looks away. She says Terrence told her that because he had spent so much money on her, she needed to help out. He took pictures of her. Then he told her she needed to be nice to his friends to pay back what she owed him. She has been leaving at night to go to hotels with men Terrence arranges. She says, "I didn't want to at first, but Terrence said I owed him. He said he'd post the pictures online and tell my foster mom I was a whore if I didn't do it. I don't know how to stop. I have nowhere else to go. At least Terrence says he loves me. Brianna then looks at you with tears in her eyes and says, "You can't tell anyone. Promise me you won't tell anyone. It would ruin everything." This case requires us to understand the grooming process and the complex psychological dynamics at play. Terrence's manipulation of Brianna followed a textbook lover boy or Romeo pimp trajectory. In the first phase, targeting, Terrence identified Brianna on social media. Her status as a foster youth with multiple placements made her an ideal target. A young person likely lacking stable adult support, possibly with a history of trauma and hungry for love and belonging. In the second phase, grooming and trust building, he showered her with attention, flattery about being beautiful and special, and gifts including the bracelet, phone, and clothes. He filled the emotional void created by her unstable home life, positioning himself as the only person who truly loved and cared for her. In the third phase, isolation, he encouraged her to sneak out, pulling her away from any oversight from her foster family or school. In the fourth phase, creating obligation and debt bondage, once he had established emotional dependence, he reframed his gifts as a debt. He told her she needed to help out and pay back what she owed. In the fifth phase, coercion and exploitation, he used threats of posting intimate pictures, a form of sextortion, and psychological manipulation to compel her to engage in commercial sex acts with his friends and men he arranged. Trauma bonding is a powerful psychological attachment that forms between an abuser and a victim as a result of a cyclical pattern of abuse interspersed with intermittent positive reinforcement. The victim becomes emotionally dependent on the abuser and may defend them or be reluctant to leave. Brianna's statement, "At least Terrence says he loves me," is a clear indicator of trauma bonding. Despite being coerced into commercial sex, she clings to his expressions of affection. She sees him as her only source of love and security, not as her exploiter. This is a survival mechanism, not a choice, and it is crucial that healthcare professionals do not judge her for these feelings or try to forcibly break the bond. It must be understood as a symptom of the abuse she has endured. Now, regarding Brianna's request for a promise of secrecy, the nurse cannot make that promise. Brianna is a 16-year-old minor who has just disclosed that she is being commercially sexually exploited. This is, by definition, child sex trafficking and child abuse under Florida law. The nurse is a mandatory reporter. There is a legal, non-discretionary duty to report this disclosure to the Florida Abuse Hotline at 1-800-96-abuse. Making a promise of secrecy and then breaking it would be a profound betrayal of trust. It is far better to be honest with Brianna from the outset about the limits of confidentiality. Brianna presented with a constellation of risk factors that made her a prime target for trafficking. Her involvement with the child welfare system is significant because youth in foster care are among the most vulnerable populations for trafficking. Her multiple foster placements created instability and a lack of permanent, trusting relationships, leaving her searching for connection. There may be a potential history of trauma, as multiple placements often correlate with underlying trauma or behavioral issues. Her desire for love and belonging was exploited, as she explicitly stated that Terrence told her he would take care of her, unlike her foster families. He exploited her unmet need for a stable, loving relationship, and her social media presence provided the opportunity for Terrence to find and target her online. The conversation about reporting must be handled with extreme care. A trauma-informed approach might sound like this: "Brianna, thank you so much for trusting me with this. What you've shared is incredibly important, and I want you to know that what Terrence is doing to you is wrong. It is not your fault, and you are not in trouble. I care about your safety very much, and that is why I have to be honest with you. Because of what you've told me, I am required by law to make a report to people whose job it is to help protect young people like you. This isn't about getting you in trouble. It's about getting you help and making sure you are safe. I know this might be scary, but I will be with you through this process. The people I report to, at the Department of Children and Families, their goal is to help you. Can you tell me more about what's happening so I can give them the best information to help you?" This approach validates her, is honest about the legal requirement, reframes the report as help rather than punishment, and offers ongoing support. Our sixth and final case study addresses an often overlooked population: male victims of sex trafficking. You are a nurse practitioner at a walk-in clinic in a strip mall in Kissimmee, Florida. A young man who gives his name as Chris presents complaining of a painful rash in his groin area. He appears to be in his late teens or early 20s, though he seems uncertain about his exact birth date when filling out paperwork and declines to provide an ID, saying he lost his wallet. He pays in cash. Chris is thin and appears exhausted. He avoids eye contact and seems jumpy. On examination, you diagnose him with genital herpes. When you begin to discuss the diagnosis and treatment, Chris becomes agitated and says, "Just give me the pills. I have to get back. He'll be mad if I'm gone too long." You gently ask who he is. Chris pauses, then mutters, "My sponsor. He's the one who got me this place to stay. I owe him." When you ask Chris about his living situation and what he does for work, he becomes evasive. He says he lives in a house with some other guys and that he does parties. When you ask what he means by parties, he shuts down and says, "Look, can you just write the prescription? I really have to go." You notice Chris has what appears to be a faded barcode tattoo on his inner wrist. When you ask about it, his face flushes with shame and he pulls his sleeve down, refusing to discuss it. This case is crucial for understanding that trafficking affects all genders. While public awareness of trafficking often focuses on female victims, males are also trafficked for commercial sex, though this is frequently underreported and underrecognized. Indicators in Chris's presentation include the diagnosis of a sexually transmitted infection, specifically genital herpes. The reference to a sponsor who controls his living situation and to whom he owes something is suggestive of a pimp or trafficker. The phrase "does parties" is common slang for commercial sex, particularly in the context of group encounters. Living in a house with other guys could indicate a trafficking house. His fear of angering his sponsor and urgency to return indicates control. The branding tattoo in the form of a barcode is highly significant. His lack of identification and uncertainty about his own birth date suggest he may have been trafficked for a long time, possibly as a minor, and may have had his documents taken. His overall presentation of exhaustion, nervousness, evasiveness, and shame complete the picture. Male victims of sex trafficking face significant stigma and may be even less likely to self-identify or seek help than female victims. In the context of sex trafficking, sponsor is a term sometimes used for a person who controls a victim, providing housing, drugs, or basic needs in exchange for the victim generating income through commercial sex. It implies a transactional relationship built on dependency and exploitation. Doing parties is a euphemism for engaging in commercial sex acts, often at private gatherings where clients are present. These are not benign social events. They are venues for commercial sexual exploitation. Chris's inability to confirm his birth date and his lack of ID create significant ambiguity. He appears to be in his late teens or early 20s, but his true age is unknown. If there is any reasonable possibility that Chris is under 18, he would be a minor victim of sex trafficking, triggering a mandatory report to the Florida Abuse Hotline. Given the uncertainty, the clinician should err on the side of caution. If the clinical judgment is that Chris could plausibly be a minor, a report should be made. If he is clearly an adult, the approach shifts to offering resources through the NHTH while respecting his autonomy to decline help. Documenting the uncertainty about age is important, using language such as, "Patient appeared to be approximately 18 to 22 years old. Patient was uncertain of exact birth date and provided no identification. Chris is resistant and wants to leave. The clinician cannot force him to stay or to accept help. The single most important action is to provide him with a lifeline by discreetly giving him the National Human Trafficking Hotline number, 1-888-373-7888. This can be written on a prescription pad, tucked inside a medication bag, or given on a small card. Accompany it with a brief, non-judgmental statement. "I want you to have this number. It's for people who might be in difficult situations. It's confidential." You can call them anytime, day or night, if you ever want to talk about your options. And Chris, I want you to know, if you ever need help, you can come back here. The goal is to plant a seed and keep the door open. The barcode tattoo on Chris's wrist is deeply significant. A barcode tattoo is a form of branding used by some traffickers to mark their victims as property or merchandise. It is a dehumanizing symbol of ownership and commodification. The location on the inner wrist, a visible but concealable spot, and the style are consistent with trafficking related branding. Chris's intense shame response, flushing and pulling his sleeve down while refusing to discuss it, strongly suggests the tattoo was not a voluntary choice and is associated with a traumatic experience. This is a high specificity indicator of trafficking. Its presence, combined with the other indicators, creates a compelling clinical picture. As we conclude this module, let's reflect on what these 6 case studies have taught us. These cases have provided an opportunity to apply the principles and knowledge from the preceding modules to realistic clinical scenarios. The diversity of the cases, spanning different ages, genders, nationalities, settings, and forms of trafficking, reflects the multifaceted nature of this crime. We examined a 15-year-old girl in a Tampa emergency department showing signs of commercial sexual exploitation. We encountered a male agricultural worker in Immokalee trapped in debt bondage. We met a domestic servant in Naples who had not left her employer's home in 2 years. We observed a young woman in a Jacksonville pharmacy whose transformation over 6 months revealed a pattern of exploitation. We spoke with a foster youth in Miami who had been groomed through social media. And we examined a young man in Kissimmee whose presentation suggested male sex trafficking. What unites all of these cases is the common thread of human suffering and the unique opportunity healthcare professionals have to intervene. In some cases, like those involving minors, reporting is mandatory and non-discretionary. In others, involving competent adults, the approach centers on building trust, providing information, and empowering the patient to make choices when they are ready. In all cases, the principles of trauma-informed care guide our interactions. Prioritizing safety, building trust, offering choice, empowering the patient, and approaching each person without judgment. Remember that your role is not to make a definitive determination of trafficking status. That is the responsibility of law enforcement investigators. Your role is to recognize concerning patterns, respond in a safe and patient-centered manner, and ensure that patients are connected to the appropriate resources and protective systems. Sometimes that means making a mandated report to the Florida Abuse Hotline. Sometimes it means discreetly providing the National Human Trafficking Hotline number. Always, it means treating every patient with dignity, compassion, and respect. The knowledge you have gained through this course and the critical thinking skills you have exercised through these case studies may one day help you recognize a victim of trafficking in your own practice. In that moment, you will have the opportunity to be a lifeline, to plant a seed, to keep a door open. That opportunity is a privilege and a responsibility that comes with being a healthcare professional. Thank you for your dedication to learning about this difficult but vitally important topic. Your commitment to recognizing and responding to human trafficking can make a profound difference in the lives of survivors. We will now review the exam questions to solidify your understanding of human trafficking recognition and response for Florida nurses. Question 1. Under federal and Florida law, which statement accurately describes the legal standard for human trafficking of a minor for commercial sex? The correct answer is any person under 18 induced to perform a commercial sex act is a victim regardless of whether force, fraud, or coercion can be proven. Rationale. This is a critical legal distinction that healthcare professionals must understand. When it comes to minors, the law recognizes that children cannot legally consent to commercial sex under any circumstances. Therefore, the prosecution does not need to establish that force, fraud, or coercion was used against the minor. The simple act of inducing, recruiting, or harboring a person under 18 for commercial sex constitutes trafficking. This legal framework exists specifically to protect children and removes the burden of proving coercive means when the victim is a minor. Question 2. Which of the following is recognized as a significant risk factor that increases an individual's vulnerability to human trafficking? The correct answer is history of abuse, trauma, or adverse childhood experiences, commonly known as ACEs. Rationale: research consistently demonstrates that individuals with histories of childhood abuse, neglect, sexual assault, or domestic violence are at significantly elevated risk for trafficking victimization. Traffickers are skilled at identifying and exploiting the vulnerabilities created by unresolved trauma. These individuals may have disrupted attachment patterns, low self-esteem, or unmet needs for safety and belonging that traffickers manipulate. Studies conducted in Florida have specifically found that a high number of adverse childhood experiences is a statistically significant predictor of trafficking victimization, making trauma history one of the most important risk factors for healthcare professionals to recognize. Question 3. Which of the following clinical indicators should raise suspicion of human trafficking in a patient? The correct answer is a patient with branding tattoos such as names, symbols, or barcodes combined with an inconsistent or scripted history. Rationale: branding tattoos represent one of the most specific physical indicators of trafficking. Traffickers often mark their victims with tattoos that signify ownership, including names, symbols, crowns, dollar signs, or even barcodes. When these physical findings are combined with behavioral red flags such as a patient providing vague, inconsistent, or rehearsed-sounding responses to questions about their history, the combination creates a significant clinical concern for trafficking. Healthcare professionals should note that victims are often coached on what to say and may appear nervous or unable to elaborate on their stated history. The presence of both physical and behavioral indicators together strengthens the index of suspicion. Question 4. Which of the following best describes a core principle of trauma-informed care when working with potential trafficking victims? The correct answer is offering choices whenever possible to restore a sense of agency and control to the patient. Rationale: trauma-informed care recognizes that trafficking fundamentally strips victims of their autonomy, power, and voice. Traffickers maintain control through coercion, manipulation, and removal of choices. A trauma-informed clinical approach seeks to counteract this by restoring agency to the patient. This means offering choices whenever clinically appropriate, even small ones like where to sit, whether to have the door open or closed, or what order to address concerns. Empowerment, voice, and choice represent a foundational principle of trauma-informed care that helps rebuild the patient's sense of self-determination and begins the process of healing from the powerlessness imposed by trafficking. Question 5. A Florida healthcare professional suspects a 15-year-old patient is being trafficked for commercial sex. What is the legally required reporting pathway? The correct answer is the Florida Abuse Hotline at 1-800-96-ABUSE, operated by the Department of Children and Families. Rationale: Florida law designates healthcare professionals as mandatory reporters of child abuse, and human trafficking of a minor falls squarely within the legal definition of child abuse. When a healthcare professional suspects trafficking of a patient under 18, they are legally obligated to report to the Florida Abuse Hotline. It is essential to understand that calling the National Human Trafficking Hotline, while a valuable resource, does not satisfy this mandatory reporting requirement. The Florida Abuse Hotline connects directly to the Department of Children and Families, which has the legal authority to investigate and intervene in child abuse cases. Failure to report to the proper state authority can result in legal consequences for the healthcare professional. Question 6. When documenting suspected human trafficking in a patient's medical record, which approach reflects best practices? The correct answer is use direct quotes from the patient, describe physical findings in detail, and record observations objectively without conclusory labels. Rationale: proper documentation in suspected trafficking cases serves multiple purposes, including continuity of care, legal evidence preservation, and communication among providers. Best practices require that documentation be objective, factual, and free of subjective conclusions. Healthcare professionals should record the patient's exact words using quotation marks, describe physical findings such as injuries, tattoos, or signs of malnourishment with clinical precision, and note behavioral observations without interpretation. Conclusory statements, such as labeling someone a trafficking victim, should be avoided because the clinician's role is to document what they observe and hear, not to make legal determinations. Thorough, objective documentation can later support investigations and legal proceedings if the patient chooses to pursue them. Question 7. Which of the following correctly identifies types of services needed by human trafficking survivors along with appropriate resources in Florida? The correct answer is emergency housing, mental health treatment, and legal AID, with resources including the National Human Trafficking Hotline at 1-888-373-7888 and the Florida Department of Children and Families. Rationale. Human trafficking survivors require comprehensive wraparound services to address their complex needs. Emergency housing provides immediate safety and stability. Mental health treatment addresses the significant trauma, including post-traumatic stress, depression, and anxiety that survivors commonly experience. Legal AID helps survivors navigate immigration issues, criminal record expungement, and civil matters. The National Human Trafficking Hotline serves as a critical national resource that can connect survivors with local services anywhere in the country. In Florida specifically, the Department of Children and Families oversees specialized programs including certified safe houses for minor survivors. Question 8. Which statement accurately reflects the reality of human trafficking as opposed to common misconceptions? The correct answer is D. A person can be trafficked by someone they know, including romantic partners or family members, and psychological coercion is more common than physical force. Rationale. Public perception of human trafficking is often shaped by dramatic media portrayals that do not reflect the typical reality of trafficking situations. Research shows that a significant number of traffickers are people known to the victim, including romantic partners, spouses, parents, and other family members. This is sometimes referred to as familial trafficking or intimate partner trafficking. Furthermore, the most common methods of control are psychological rather than physical. Traffickers use manipulation, false promises, emotional abuse, threats against family members, debt bondage, and fraud to control their victims. Physical force, kidnapping, and restraint, while they do occur, are less common than these psychological methods. Understanding this reality is essential for healthcare professionals because victims may not present in the stereotypical way that media depictions suggest. Question 9. A patient presents with a companion who insists on remaining in the exam room, answers all questions on behalf of the patient, and holds the patient's identification documents. The patient appears fearful and avoids eye contact. What is the most appropriate initial action? The correct answer is C. Use a routine clinical pretext, such as obtaining a urine sample, to separate the patient from the companion and speak with them privately. Rationale. The scenario describes several classic red flags for trafficking, including a controlling companion who speaks for the patient, possession of the patient's identification documents, and a patient who appears fearful and avoids eye contact. In this situation, the most critical first step is to create a safe opportunity to speak with the patient alone. Directly confronting the companion could escalate the situation and potentially endanger the patient. Using a routine clinical pretext, such as needing to collect a urine specimen, taking the patient for imaging studies, or conducting a private physical examination, allows the healthcare professional to separate the patient without raising the companion's suspicion. Once alone with the patient, the clinician can gently assess the situation, build rapport, and offer resources. This approach prioritizes patient safety while creating an opportunity for intervention. Question 10. When a healthcare professional suspects an adult patient is being trafficked and the patient is not in imminent danger, what is the recommended approach? The correct answer is D. Engage the patient, respect their autonomy, and offer to connect them with the National Human Trafficking Hotline, 1-888-373-7888 as a resource. Rationale. The approach to suspected trafficking differs significantly between adult and minor patients. For adult victims who are not in imminent danger, the recommended approach centers on empowerment and respect for autonomy. Unlike cases involving minors, there is no mandatory reporting requirement to the Florida Abuse Hotline for adult victims. Healthcare professionals should engage the patient with compassion, provide information about available resources, and offer to connect them with the National Human Trafficking Hotline. This resource provides specialized support for trafficking victims and can connect them with local services when they are ready. It is essential to respect the adult patient's autonomy and decision making, even if they choose not to leave their situation at that time. Forcing action can be counterproductive and dangerous. The healthcare encounter may be planting a seed that helps the patient seek help in the future when they are ready. This concludes the exam review for human trafficking awareness for Florida nurses. Remember, as a healthcare professional, you are often in a unique position to identify and assist trafficking victims. Your knowledge of the legal requirements, clinical indicators, trauma-informed approaches, and available resources can make a life-changing difference for vulnerable patients in your care.